విజయ్
సార్
8:05 వరకు వెయిట్ చేయి. 8:05 తర్వాత స్టార్ట్ చేస్తాయి ఇంకా.
ఓకే సార్.
ఈలోపు కుదిరితే ఆ క్వశ్చన్లు ఏమైనా దొరుకుతాయేమో 2 సంపాదించు.
సార్ సార్
గుడ్ మార్నింగ్ ఓంకార్.
సార్ గుడ్ మార్నింగ్ సార్. Hello.
Sir.
Vijay.
Sir.
It's 8:05. Huh?
Okay, sir.
We'll start. Okay.
Okay, sir.
Good morning, all. Today's class is about oxygen therapy, which is the question for postgraduates, exam going batch, and also I hope Vamsi. I think he's going for practicals. So please focus on the entire class. At the end of the class, there will be 2 questions also. I hope all the PGs will participate. Vijay, start the class.
Yes, sir. Sir, good morning to all. Sir, I'm audible, sir?
Yes, yes.
Yeah, okay, sir. Thank you, sir. Sir, I'm going to present a seminar on oxygen therapy in COVID-19 infection. Coming to the introduction part. COVID-19 virus is a single stranded RNA, and which virus is enters into our body through the ACE2 receptors. Coming to the main proper topic, these are the common indications for oxygen and my today objectives: indications of oxygen therapy, oxygenation targets, and types of oxygen devices, ventilation strategies, which is non-invasive and invasive, and some complications associated with the oxygen therapy. These are main indications for oxygen therapy in COVID-19 patient. Some physiological and etiological parts. In physiological parts, there is ventilation perfusion mismatch and diffusion impairment, and right to left side, low FiO2 and hypoventilation. Coming to the etiological parts, there is pneumonia, aspiration event, airway obstruction, pulmonary edema, COPD exacerbations, pulmonary embolism, and pneumothorax. These are all etiological factors for a patient which required oxygen therapy. And also these are indications for dyspnea in COVID-19 patient, pre-existing any heart failure, chronic lung diseases, anemia. These are the oxygen targets in COVID-19 patient. In moderate cases, the target SpO2 is 90-96% in normal patient, and in COPD patient, which is 88-92%. And in severe cases, the target SpO2 is greater than 90% in non-pregnant adults. In pregnant women, greater than 92 and 96% SpO2 is maintained. These are the oxygen delivery devices. First one is nasal cannula, then simple face mask, then partial rebreather face mask, and non-rebreather face mask, venturi mask, high flow nasal cannulas, non-invasive ventilation, and invasive ventilation. Coming to the nasal cannulas, these nasal cannulas are also known as a nasal prongs, used in stable patient with minimal requirement of oxygen, which the respiratory is not more than the 20 per minute. Patients are well tolerated and do not interfere with the eating and speaking, which is deliver the constant airflow to the nasopharynx and oropharynx. It is acts as a reservoir of 50 ml capacity, and maximum it delivers up to 0.4 FiO2 and flow up to the 6 liters per minute. The higher flow rates dries the nasal mucosa and increase the chances of infection rate in this patient. And also for a respiratory rate of 30 to 35 per minute, the FiO2 decreases by the 20 to 30% per minute. It's a simple face mask, also called Hudson mask. This is a lightweighted plastic mask. It adds the 100 to 200 ml to the capacity of the reservoir, and it delivers the oxygen at flow rates of 6 to 10 liters per minute. The 6 liter is the minimum flow rate is needed to clear the exhaled gases from the mask. And coming to the partial rebreather face mask, the reservoir capacity increases with a bag. There is no walls between the mask and the reservoir. This is the main difference between the rebreather face mask and partial rebreather face mask is no walls between the mask and reservoir. The first 1/3 of the expiratory gas, which has not participated in the gas exchange, is exhaled back into the reservoir. The next 2/3 is exhaled out via the side ports. So the next breath therefore has a higher FiO2 of oxygen. The delivery of FiO2 is 0.6 to 0.8 at the flow rate of 6 to 10 liters per minute. So the collapsed bag can be increased the work of breathing in patient. The non-rebreathable face mask, similar to the partial rebreather mask, except the connection is valve present in mask. Theoretically, these can deliver the 100% oxygen, practically 0.6 to 0.8 daily. And also the flow rate is 6 to 15 liters per minute. So these rebreathers, non-rebreathable mask, do not decrease the work of breathing significantly. Coming to the high flow nasal cannulas. So it's generating high flow oxygen at 40 to 60 liters per minute. FiO2 up to 100% can be delivered. Used in non-COVID hypoxemic respiratory failure patient also. Coming to the advantages, it is a small pliable nasal prongs, and also warming and humidification of secretions. Continuous positive airway pressure effect allows the patient to eat and speak and drink. Some patients not settled by the HFNO may need NIV or other intubation. It relieves the discomfort of air hunger. These are the uses of HFNC. And first of all, two parameters need to be set in HFNC. First one is flow rate and the next one is FiO2. The flow rate is usually set first. The range is 5 to 60 liters per minute. Typically, it initiates rate increase 20 to 35 liters per minute. After that, FiO2 is set next to achieve desired target of saturation ranges of 21 to 100%. The flow rate is increased in increments of 5 to 10 liters per minute. If the respiratory rate, oxygenation fails to improve and breathing remains labored. The flow rate should be maximized in an attempt to keep the FiO2 less than 60%. Switch to conventional low flow nasal cannula system. Once the flow rate reaches less than 20 liters per minute and FiO2 less than 50%. Coming to the non-invasive ventilation. These are main indications for non-invasive ventilation. Hypoxemia, which is refractive to the non-ventilative oxygen devices. It prevents the need for intubation. These are advantages and reduce the work of breathing. It's a bridge to intubation. There are some contraindications to the non-invasive ventilation. Patients unable to protect the airway and excessive secretions, vomiting. Advantages is minimal risk of exhaled air dispersion. In non-invasive ventilation, these are types of some masks, which is facial mask, oronasal mask, and nasal mask, some pillows or mouthpiece and helmet. The helmet, the advantages is minimal risk of exhaled air dispersion and lower chance of leakages and effective lowering the work of breathing. The helmet NIV reduces the mortality and decreases the need for intubation in non-COVID-19 hypoxemic respiratory failure patient. Additionally, the non-invasive ventilation may cause harm to the patient.
Class జోషి గారు అదే ఇంట్లో అలా
హలో
రమణ ప్రసాద్ ఒకసారి మైక్ ఆపేరా షాప్ పెట్టారా రమణ ప్రసాద్ ఇక్కడే ప్రసాద్
shall continue, sir?
జమ్మల మడక రమణ ప్రసాద్ సార్ కొంచెం మైక్ ఆపేరా మీది ఇది మైక్ ఆపేరా
Yes, sir. Shall I continue, sir? Yes, sir. So non-invasive ventilation may cause harm to patients through the two different mechanisms, which is leading to worsening of the patient outcomes. One is lack of ability to control the tidal volumes, and another one is the possible delay in intubation and mechanical ventilation. So the use of NIV in patients with ARDS has a failure rate of 50% in COVID-19 patient. These are all contraindications for NIV. Uncooperative patient, reduced consciousness, unable to protect airway, unstable cardiorespiratory status, some facial esophageal gastric surgeries, pneumothorax. Coming to the invasive ventilation, the mechanical ventilation is a useful modality for patients who are unable to sustain the level of ventilation necessary to maintain the gas exchange functions, oxygenation, and carbon dioxide elimination. So mechanical ventilation is a technique in which the energy is supplied in a predetermined way to augment and replace the patient's muscles in performing the work of breathing. When switching NIV to invasive ventilation, which is increasing drowsiness, work of breathing, and oxygen requirement. there is hemodynamic instability, vomiting and risk of aspirations, and progressive radiographic severity. These are leading to switching the NIV to NIV into the invasive ventilation, and also falling respiratory system compliance, increased need for positive pressure ventilation, and increase the minute ventilation. Ventilator management in ARDS patient, which is unclear, but the strategy aim to prevent ventilator-induced lung injury by avoiding alveolar over distension and hyperoxia, and cylindrical cyclical alveolar collapse. So ARDS is the inflammatory process and also known as a non-cardiogenic pulmonary edema. According to the Berlin's definition, the oxygenation divides into mild, moderate, and severe. In mild, there is a PaO2 FiO2 ratio. PaO2 by FiO2 ratio is 200 to 300 millimeters of mercury, and in moderate cases 100 to 200 millimeters of mercury, and in mild cases, in severe cases less than 100 millimeters of mercury. In all mild, moderate, severe, with PEEP 5 centimeters of water. So in main ARDS patient, there is alveolar equipment maneuvers are provided in this patient, which is increased PEEP, prone position. The prone position is help to reduce the overinflation of lung and promotes the alveolar equipment and reduce the VQ mismatch. And intermittent mandatory ventilation in ARDS patients is reduce the elastance and increase the compliance. These are the lung protective ventilations. The target tidal volume should be 6 to 8 ml per kg, and also set PEEP to prevent the lung derecruitment. During each PEEP setting, the monitor of hemodynamics, respiratory complex, and gas exchanges, and also the plateau pressure maintenance up to less than 30 centimeters of water. If the plateau pressure is greater than 30 centimeters of water, then we consider the reducing the tidal volume minimum of 4 ml per kg, and also reduce the PEEP, allowing higher plateau pressure in patient with obesity and reduced chest wall compliances. These are the potential determinants and effects of associated with the positive pressure ventilation, which cause reduced venous return and afterload, and hypotension, reduced cardiac output, leads to barotrauma, and also it causes ventilator-induced lung injury, and cause air trapping, may increase the dead space, which is the compression of capillaries. These are the rescue therapy in COVID-19 patient, prone positioning during mechanical ventilation. It causes refractory hypoxemia. The PaO2 FiO2 of ratio is less than 150 mm of Hg during the respiration, and FiO2 of 0.6 despite the appropriate PEEP. In randomized trials, in intubated patients with ARDS, placing the patient in the prone position for 16 hours per day has improved oxygenation and reduced the mortality. Finally, come to the conclusion. The medical oxygen maybe is treated as equivalent to a drug. So oxygen is a drug. Use of oxygen should be judicious, and it causes so many side effects. And devices should be selected based on the need for the patient. Each device has its limitations, and mechanical ventilation can be a double-edged sword. And also intubating everyone early can be disastrous, and ventilation strategies need to be individualized. Thank you, sir.
Thank you very much, Vinay. Very short and sweet, and all points have been covered.
Thank you,
And
sir.
that too, another one more thing is very good that you have covered very fast so that we can have a lot of discussion.
Thank you, sir.
Nice joke also for Omicron. Yeah, just want to understand, you said hypoxia. How do you identify the hypoxia earliest?
Sir, hello.
Dr. Vinay, Omkar, can I ask questions?
Yes, sir. Sure, sir. Sure. Please, sir. Ask questions, sir.
Hypoxia ni mundu ela meeru identify chestaru?
Sir, if the patient have increased work of breathing, there is increased hemodynamic instability.
How do we calculate work of breathing?
According to the respiratory rate, sir.
Etla work of breathing calculation equation. Just ఊరికి వర్క్ ఆఫ్ బ్రీతింగ్ గురించి ఎలా చెప్తావు? నాకు తెలియదు కదా, నేను చూడలేదు పేషెంట్ ని, నువ్వు చూసావు. హౌ డు యు సే దట్ వర్క్ ఆఫ్ బ్రీతింగ్ ఇస్ ఇంక్రీస్డ్?
Go for ABG, sir.
వర్కౌట్ బ్రీతింగ్ ఏబిజికి సంబంధం ఏంటి అసలు?
And these patients have
ఫస్ట్ హైపాక్సియా ఎలా డెఫినేషన్ ఆఫ్ హైపాక్సియా ఏంటి?
హలో విజయ్.
సార్.
సార్ ఏమడుతున్నారు సరిగ్గా?
హలో సార్.
హైపాక్సియా డెఫినేషన్ ఏంటి?
ఎస్ సార్, ఇది లో ఆక్సిజన్ కంటెంట్ ఇన్ బ్లడ్ సార్.
ప్రతిదానికి ఒక నంబర్ ఉంటది కదా. లో అంటే ఎంత? అందరికీ ఒకటే లో కాదు కదా.
ఎస్ సార్.
ఎంత మరి?
సాచురేషన్
చెప్పండి.
SpO2 is less than 90 sir.
SpO2 less than 90. సో లెస్ దాన్ 90 వచ్చేందుకు మీరు ఎవరికి ఆక్సిజన్ పెట్టవా?
Depends upon patient.
ఫ్యాక్టర్స్ SpO2, రెస్పిరేటరీ రేట్, ఇంకేం చూస్తావు?
అసలు అది కాదు. హైపాక్సియా అంటే డెఫినేషన్ ఏంటి? ఒక నంబర్ ఉంది, ఒక డెఫినేషన్ ఉంది. జస్ట్ ఊరికి హైపాక్సియా అంటే ఆక్సిజన్ తగ్గడం కదా, అది అందరికీ తెలుస్తుంది కదా. నర్సెస్ తెలుస్తుంది, టెక్నీషియన్ తెలుస్తుంది. యాజ్ ఎ డాక్టర్, వెన్ డు యు సే ఇట్స్ హైపాక్సియా? అండ్ మనం జూమ్ మీటింగ్ లో ఉన్న అడ్వాంటేజ్ ఏంటంటే వెంటనే టకటక సెల్ ఫోన్ ఇంటర్నెట్ లో చూసుకుంటే చెప్పుకోవచ్చు కదా. మనిషి కనపడం కదా. ఏ ఓంకార్? Hello, nobody is talking. My voice is not audible.
Checking in Google, sir.
Hello. When PaO2 is less than 60, breathing room air, it is called hypoxia.
Very good, sir. ఎంతమంది టీచర్లు తొందరగా ఆన్సర్ ఇస్తున్నారు. What is the correlation of workup breathing, sir?
Tachypnea and accessory muscles of respiration prominent. Intercostal muscle.
There is an equation, sir.
Equation, I don't know, sir.
Students తెలుస్తారని.
సార్ ఈ ఈక్వేషన్ నాకు తెలుసు సార్, చెప్పండి సార్.
ప్రెషర్ వాల్యూమ్ ఏరియా అంటే ప్రెషర్ వాల్యూమ్ వర్కౌట్ బ్రీతింగ్ వస్తుంది సార్.
Pressure into volume.
కాదు ఓంకార్, నేనేది ప్రెషర్ అండ్ వాల్యూమ్ వర్క్ కాదంటలేదు. నేనేది ఇప్పుడు మామూలుగా నువ్వు క్లినికల్ గా చూసేటప్పుడు ఇప్పుడు ఆయన హీ హాస్ గివెన్ వెరీ గుడ్ క్లియరెన్స్ దట్ హైపాక్సియా వచ్చినప్పుడు ఇట్ ఈస్ నాట్ జస్ట్ సింప్లీ వైటల్స్, తర్వాత యాక్సరీ మజిల్స్ ఇవన్నీ పెరుగుతాయని. బట్ నార్మల్ గా మోస్ట్ ఆఫ్ ద పీపుల్, యంగ్ పీపుల్ వచ్చినప్పుడు, ఇప్పుడు కోవిడ్ లో పర్టికులర్ గా వెన్ డూ యూ స్టార్ట్ ఆక్సిజన్, SpO2 తగ్గితే నువ్వు ఆక్సిజన్ పెట్టావంటే వర్కప్ పెట్టినప్పుడు చూడాలి కదా ఫస్ట్. He must be taking, because he must be taking around 30 to 40 times of respiration, and SpO2 will be 98 and 99. So you think there is no hypoxia? That is where the entire problem comes. That is where we calculate workup breathing. Pressure into volume is a work. Then when you see that as Raman Prasad said clinically, if axillary muscles are working or the breath holding time is less and the heart rate is rising, because to compensate for the hypoxia, and because if we see the oxygen SpO2, the SpO2 is equivalent of heart and lung both. It is not just saturation. So when all these things are happening, so that is where you look at workup breathing. And mainly we all know that workup breathing perigindani cheppadaniki everybody has to understand in detail about PO2, SpO2. As you said, PO2 less than 60, and particularly in COPD patients, you may be having a less SpO2, and poisoning patient, you may be having less SpO2, but a PO2 may be normal. If the workup breathing is not increased, hypoxia is there, you accept up to 92 or 94, but the target percentage of the oxygen should be above 94, and you should not give, if the workup breathing is not increasing, you don't give oxygen. If the workup breathing increases only, you have to give oxygen if the SpO2 falls down. That's another point we need to note, because just because SpO2 is fallen down by COPD patients, you will be doing more harm than the benefit. So those things are important now, Omkar. That's why I'm just asking.
Thank you, sir. Sir, even we have two questions. Vijay, question.
Sir.
Question, sir. Bite.
Okay. Sir, when should invasive ventilation be initiated in patient with COVID-19 requiring NIV? Sir?
No change in indications of ventilation. Whenever there is a PO2 FiO2 ratio is falling and more than not increasing with your incremental oxygenation or the supportive measure, because the workup breathing is increasing, you may not need most of the, sometimes in COVID, you may not need oxygen. You may need less oxygen, you may need more support. That's the reason that why the COVID has been benefited with the HFNO mission. Because HFNO mission, you can still have a high 60 or 7 liters of flow, as well as FiO2 of only 21% can be given. Because the reason is different. So the lung, how much lung is being spoiled depends on that. The same way NIV, whenever you start an NIV, you have to look at the patient is having less than 7.2 pH, don't try NIV. You have to go for intubation. But in COVID, first wave and second wave, we started with only NIV. We ended with NIV and declared with it NIV. But it is not so. Any indication of intubation is if the NIV and not maintaining with PO2 of more than 60 with FiO2 of higher than 80%, then he is likely to go for indication for this one. Because delay in intubation will cause more problematic, but recovery will become delay. At the same time, the Dr. Vinay was telling one thing, ventilator is a double-edged sword. I don't know whether the word is correct or not, because double-edged sword means you putting ventilator also dangerous, and you're putting don't put ventilator also dangerous. That's what you mean to say, Dr. Vinay?
Yes, sir.
So it is not so, because ventilation, there is a clear-cut indications are there. So you have to go for invasive ventilation. The only problem is you should be trained, as you said, the clear-cut guidelines you are told, how to prevent villi, how to prevent. I didn't understand circular collapse of alveoli. I don't know what does it mean. Is it a meaning of prevention of stress and strain? Or,
yes, sir.
Yeah.
Over alveoli.
Yeah, over alveoli.
Yes.
So that's what you told. So I remember. So when you are doing that, as you said, plateau pressure, peak pressure, so all these things, because we all know recently we heard from the lot of thesis and theoretical practice, H lung, H type lung, L type lung, because there you will not be having this plateau pressures properly. That's what is a difficulty. So there you have a more of H time, then it becomes. Yeah, I think Sharda has given the work of breathing clear cut. The tidal volume multiplies with the transpulmonary pressure. So Sharda, you can explain, no issue. And the thing is, another point here is that prevention of damage. And he was telling about 16 hours of lung prone position will definitely improve. Then only you have to think about it. But the issue is here, the indications of ventilation is same for a COVID patient, for non-COVID patients. There will not be any difference.
Okay, sir. Thank you, sir.
Sir, actually, we have some options, sir, in the question. Vijay.
Sir.
Complete ga chadu sir.
Okay.
What is a better mode for ARDS?
There is no better mode for ARDS, sir. Whichever, like anesthesiologist, we know whether we give midazolam, whether we give diazepam, whether we give dexmedetomidine or induction thio, whatever it is. Whoever you are comfortable with a long time and a better management, you know that is a better. So same way in ventilator, there's no mode except what, there's no advanced mode or benefit. Like for example, our intensivist will try only APRV because the new mode he has learned all the time and it's better. We have to look at the pro and cons. Previously, the present ventilators having a lot of technology to cut off and prevent the complications. So whether you go for volume control mode, you have to think about the peak pressures and plateau pressures and prevent the wheelie. And if you are thinking about the pressure control mode, you have to monitor the tidal volume to achieve the target tidal volume and make sure that they are not going to trouble because the stress and strain reduce. So it is whenever you are seeing, like if the patient is having ARDS, which stage of ARDS you are putting the patient on ventilator? First, second, third, fourth stages are there in acute phase. So you put the patient, depends on when you put the patient relaxant, you put the patient on prone position, that kind of time to reach the target tidal volume. And as we said, there is a preventive lung injury to be done only by 6 ml per kg body weight. And you have to, if you put the volume control, put the 6 ml per kg body weight. You put a pressure control, you try to achieve with the pressure of whatever pressure you set for the 6 ml per kg body weight, ideal body weight, you calculate accordingly. And you have to monitor. The main thing is in the monitoring, you should monitor the tidal volume in the pressure control. You should monitor the peak and plateau pressure in the volume control. Another point is, most of the times what we miss in the ventilator is whenever we go, we only see how much tidal volume we have set in. It is not that. In the monitor, how much tidal volume, expected tidal volume it is coming in the monitor. That is more important, because even if you put a 400 ml, the patient must be getting only because of 150 or 200 ml because of the, that is the reason I have seen many patients, sir, I have put 400 ml of tidal volume, I have put 20 times respirated, I have put a PEEP of 8, sir. But if we go and see the pH will be 6.9 or 7.1 and the PCO will be 90, 100 because sir, the tidal volume is not reaching because of the stiff lung because of ARDS. So depends on the what set you are doing, whether you are giving relaxant or you are not giving relaxant. But we are not supposed to give relaxant unless required. That's true. Not like before, you have to give only sedation unless you put hypothermia or prone position or those kind of things. And always go for if the pressure control is there. Certain people, because most of the people I have seen, my pulmonologist likes one mode, and my critical care specialist likes one mode. It depends on the what they like, maybe because they train into that more and they're very user friendly in that way. So like somebody is using a Dell and somebody is using a Mac, the methodology of Android. The same way ventilator, whatever ventilator you have to just can go on, no issue at all. The only thing I would say that previously the HFNO was not really used in COVID. Now HFNO take advantage of a lot of things, but four points. Number one, it gives humidification. Number two, yesterday our colleague Dr. Manjula went to Manipal Hospital in Bangalore and came. Now they stopped using the oxygen water in the oxygen flow meter because that is a maximum place where the infection is going to the patient. So they are just not using it. They're just using a direct air to the patient so that it can cause ARDS. Most of the times, as he was telling about oxygen will increase oxygen toxicity, but he did not mention about the toxic problems of oxygen toxicity by Vinay. So this mode of ventilation can be given by anything, depends on whether the weaning mode. In the weaning mode, previously we used to do SIME, intermittent TP trial, but the international standard of is only the breathing trial. That is a spontaneous breathing trial. That's called SBT trial. If you do for half an hour to maximum 2 hours, the same way as the previous question was when to intubate. In any NIV, if you are putting the patient on NIV, if the patient is not improving half an hour to 2 hours, you should go for intubation. You should not wait unless for 3 reasons of malignant patients, non-intubated, or like HIV and we don't want to intubate, and patient is improving all the time. Anyway, whether it's the AO2 or anything. So regarding this type of ventilation, there's no clear cut for ARDS. This is the best. Thank you, sir. Anybody else, please, seniors?
Thank you, sir. Very good explanation. But most of the people are using APRV.
That's what, sir. Because previously, if you remember, you were very much comfortable with the diazepam when you were started, but now you are using different drugs. Like that, APRV, it has come only 1 decade back. I mean, very, very good, because it is having advantage, both advantages of volume and the pressure, both advantages are there. So that's the reason. But you need to monitor the patient. That's more important. All the expect tidal volume, work of breathing, the complications.
Sir, we
For
have one
PG
more question, sir. Vijay, second question.
Yes, sir.
Options కూడా చదువు వెంటనే.
Okay, sir. So, which patient should be the first line oxygen? Which is the first line oxygen modality for an awake person with saturation below the 90%, sir?
I do not know the option what is available, but what I know is that anything he has to start with nasal prongs as a escalation goes. So
Yes, sir.
nasal prongs, then go for a, even if in oxygen mask also you have a different variety. Venturi mask is there, normal mask is there, and non-rebreathing mask is there. So different masks are there. So the
Yes.
flow with the humidified oxygen, always when you call it as, you call it as humidified oxygen. So nowadays, heated humidified is the best, not the normal humidified, because normal humidified will have a problems. So always heated humidified is the best. And it's not the percentage of 90, because only SPO to 90%, maybe you have to look at, as you said, other vitals, everything. And I don't know this what options he has. But for me,
Yes,
you
sir.
can start with oxygen mask.
Yes, sir. The options are first one is nasal prong, sir.
Mm,
Second one is non-repeating mask.
yeah.
Third one is non-invasive ventilation. Fourth one is invasive ventilation. I
So
think
then you
nasal.
still have directly nasal mask only. I mean, nasal prongs only is my opinion, because the oxygen mask is not there, no?
Yes, sir. So this is so.
Vinay, what is rapid shallow breathing index?
I think if Chaitanya or Sharada are on the group, they can discuss and they can talk, please. They're fresh from their DN. Or any senior faculty, please.
Hello?
It is a test used for weaning. Tidal volume in ml by respiratory rate. If it is less than 100, patient is going to have successful weaning.
Is it 100 or 105?
105, sir.
It's not 100, it's 105, I believe.
105, yes, sir.
And anesthesia seniors Anuradha, Manjula unnaru kada.
Questions, please, madam. Sir, actually, I thought PGs and DNB students will answer that two questions, sir.
Oh, sorry, then I might have answered wrong. They must be answering the fresh answer, which is correct. There's a lot of time, still you can discuss a lot of points, sir. Maulga, lung, what are the complications by ventilation? What are the complications by NIV? What are the complications by oxygenation, oxygen toxicity? And as he was mentioning, oxygen is a conclusion slide, oxygen is a drug. So what are the 4 points when you are prescribing oxygen to be compulsory mentioned? Whenever we write oxygen, you should write humidified oxygen. You should write through what, whether nasal prongs or oxygen mask. Then you should write when to repeat hypoxia or oxidation or ABG or what to do. Or your idea is to look for CO2, because sometimes for CO2 type are you giving or just giving for only for hypoxia.
Sir, I have one question, sir.
Please.
Yes, sir.
Is it for me or
BiPAP
for all?
compared to CPAP, sir.
Yeah.
Sir, in option, the first option
I
is
don't know.
provides ventilation assistance. Sir, I'm audible, sir.
Yeah.
Yes, sir. BiPAP compared to CPAP, sir. First option is provides ventilation assistance. Second option is increase
Go ahead.
blood pressure.
Mm.
Third option is increases heart rate. Fourth option is increases work of breathing, sir.
He's very clear cut. What is there in that to think about? Because what is it? What is the question? BiPAP or CPAP?
BiPAP compared to CPAP, sir.
BiPAP.
Compared to CPAP.
So benefit of BiPAP is asking.
Yes, sir.
On
One
DNB
is
Amshi.
వంశీ నువ్వు
repeat the
పర్మిషన్
answer?
ఇస్తే కానీ మాట్లాడు.
Any other PG can
ఓంకార్
also
నువ్వు చెప్తే
answer.
కానీ మాట్లాడి వంశీ ఓంకార్
Sir.
నువ్వు చెప్తే కానీ వంశీ మాట్లాడేమో.
అదే అన్నాను నేను కూడా.
బాబు డ్యూటీలో ఉన్నట్టున్నారు సార్. ఇంకా ఉన్నారు సార్, పీజీ ఉన్నారు. ప్రవీణ్, శకుంతల మేడం. Anyone, any student should answer this.
ఎందుకు శారదా ఉన్నట్టు? శారదా చెప్పమా.
శారదా.
ఆన్సర్ కూడా పెట్టింది. డాక్టర్ శారదా, ఆర్ యు ఆన్లైన్?
All DNBs are busy, sir.
అలా కాదు. We should discuss about this point because it is not first question. Everybody will think about the first answer, but they have given other three for this. That's important. Anybody? Naveen, Praveen, Gayatri is there.
Okay, IDCCM students.
Repeat the answers. 4 answers చెప్పండి ఒకసారి వినయ్.
Yes, sir. Yes, sir. It provides ventilation assistance. Second one is increased blood pressure. Third one is increased heart rate. Fourth one is increases work of breathing, sir.
No, it has to be first one only, but only thing is other 3 things will not be increased if properly set up. The only thing is for CPAP and BiPAP difference. First అది ఆలోచిస్తే
Yes, sir.
it's continuous positive airway pressure. It's nothing but a peep of the patient. We are increasing externally instead of invasive ventilation.
Yes, sir.
BiPAP means there is a continuous CPAP in most of the CPAP, but BiPAP you have 2 levels. One is a EPAP and IPAP. So between the EPAP and IPAP, you are delivering the tidal volume. But only thing, the problem is that if you set properly, because setting of BiPAP is more important. You properly set more than 80% of the auto PEEP, the patient is having auto PEEP, or having a minimum difference between the IPAP and IPAP should be minimum 6 to 8. Then look at the tidal volume achievement. This is different. When you do all these things compulsory, then only it is useful and beneficial. So looking at that, the first one is more useful, but it cannot increase because any BiPAP or any non-invasive ventilation, there are 5 benefits. Not only that, there is an intraventricular septum pressure. That means indirectly it reduces the load on the heart by supporting the lung. So you will reduce the heart rate. They will not be increasing the heart rate. So work of loading is reduced. And indirectly, it actually increases the venous return if properly been assessed. Because once the patient work of breathing increasing, there is a lot of oxygenation, heart rate will increase. That time the circulation will increase. And if it particularly in sepsis and ARDS, there is a volume in reduction, and because of that, the venous return will come down. So these problems are there, but that will improve. So there is a lot of another 5 benefits are there, including a lot of things. I don't remember another 2 points. When you use a BiPAP properly for the patient who is hypoxic and having a cardiac problem, even in patients on pulmonary edema, if you remember very well, BiPAP works very well. For cardiac pulmonary edema and nephropulmonary, you don't need patient to intubate. You don't have to, you can just put a BiPAP and patient will improve for all these reasons. So for that purpose, BiPAP is more useful than the CPAP. And the CPAP may be useful only for the people who are having a OSA like obesity, sleep apnea, or obstructive sleep apnea. So that is depends on the mode, but maybe a pulmonologist, somebody can explain properly and more reasoning correctly. But for me, it can never increase the heart rate, and it can never another 2 points. What it is increasing heart rate?
Increase work of breathing, sir. Increase blood pressure, sir.
So it can never increase the work of breathing because it is the proper itself. It is to reduce the work of breathing, the indication itself. And the third thing is heart rate. So heart rate, because normally you are supporting the heart rate indirectly for BiPAP, so heart rate will come down. So all these things, the only thing is both the things, CPAP and BiPAP, both will be benefited for the ventilation. So versus CPAP to BiPAP, that's what I got confusion with the question. So I need to know a little more about it exactly. What is the answer given? No, we don't have an answer, right?
No, sir. I think first one, sir, provides a ventilation assistance.
Yeah, that is a simple, very simple. It doesn't look any, because all other things are beneficial. Other things are work out, but you need to work out. It is not, we need to understand. Sometimes if it is a tricky question, it may be sometimes in the beginning, first half an hour, there may be increasing of the heart rate can happen because of the acclimatization of the BiPAP.
Acclimatization.
I don't know, Omkar, why nobody is talking, only myself talking. Srikanth is there, you are there, and other people are there. Manjula, Anuradha are there. Sorry, maybe if I'm not allowing you to talk.
No, sir. You are discussing.
What are the contraindications for NIV?
సార్ నేను చెప్పమంటారా ఇంకెవరు చెప్పమంటారా అది అడగండి సార్. ఎందుకంటే
సార్ విజయ్ చెప్తాడు. విజయ్ క్వశ్చన్ విన్న ఆన్సర్ చెప్పు. చెప్పవుగా
సార్.
చెప్పు.
Hello, sir.
Question: contraindications of for NIV.
Contraindications for NIV.
Sir, uncooperative patients, sir, extremely anxious patients. Reduced conscious.
Uncooperative only.
Yes, sir. Inability to protect the airway, sir. Those patients.
Vinay, there is something called relative contraindications, absolute contraindications. చెప్పండి.
Yes, sir. The absolute contraindications is uncooperative patients, sir. Extremely anxious patients and reduced consciousness patients, sir.
Yeah, next. Hello, Vijay. Inka.
Sir. And also unstable cardiorespiratory status, sir.
Yes. Unconscious patients, unstable cardiorespiratory.
Cardiorespiratory status patient.
What more?
And
Some trauma or burns involving the face.
Yes.
Also some surgeries, sir. Facial, esophageal and gastric surgeries. Comes under relative contraindications, I think.
Any other things?
I think raised ICP and raised IOP also relative content.
Okay, sir.
మస్కులర్ డిస్ట్రోఫీ మయోస్థీనియా ఈ టైప్ పేషెంట్స్ లో కూడా పెట్టుకోవచ్చు.
అది అబౌట్ టు టెల్ శ్రీకాంత్ సార్, మయోస్థీనియా మనం చూసాం కదా. హలో హలో sir, one more my question, sir. How frequently we have to monitor ABG in the case of ARDS, sir, or else severe respiratory disorder on ventilator? How frequently we should do ABG, sir?
నన్ను అడుగుతున్నారు సార్.
సార్ ఇది నాకు తెలుసుకోవాలండి. అంటే అంత ఫ్రీక్వెంట్ హౌ ఫ్రీక్వెంట్లీ we should do ABG?
It is of the depends. First thing is in a first ABG, what is your value? The first ABG, what are you looking for? When you put the patient on ventilator, what are you looking for? We are looking for hemodynamics. We are looking for, when you look at the ABG, what are things you are looking for in ABG? You are looking for only ABG, just for ABG and PO2, or you are looking for everything, like a status of the patient, sepsis because of the ARDS? Is it ARDS because of the cardiac problem? Is it ARDS because of this renal failure? Is it ARDS because of hypovolemia and shock? So that's the reason. What is the focus increase? ABG will have particularly not just PO2, PaO2, PCO2 is important. Ventilation is a PCO2. Then the bicarb status, acid-base balance, that's why we call it as, and electrolytes and lactate, AaDO2. All are important for us. When you're looking at ABG, first, if the pH is less in the first ABG and the other things are fine. So what is the pH? Just normal around above 7.2 above, or 7.2 above, other things are normal. Then you can wait for few more hours. But if it is less than 7.2 or 7.1, immediately you should repeat every 1 hour. Because till it becomes correct, at least to know whether you're monitoring properly, ABG will give all the things, because not just till you put the arterial line. So it depends on the day. There are surgical ventilator patient is different, medical ventilator is different, and trauma ventilation is different. Maybe not, the methods are not different, monitoring and the treatment is different. So in that, in the first day, normally the critical patient, I would like to do every 6 hours if the things are normal. But the pH is less than 7.1, less than 7.2, and I do every 1 hour for next 3 hours to see the trend of the ABGs of all parameters. And patient is on dialysis or electrolyte imbalance, you do only electrolytes. So the one point I would like to say that if you change the ventilatory settings, whether the setting is working or not, we'll come to know after 20 minutes. So when you put the patient on ventilator, you do a patient on ABG after 20 minutes. Or sometimes what mistake we do is that, most of the times, the real mistake what we do is that we put the patient on ventilator after seeing the ABG. After seeing the ABG, when you put on ventilator, because of it is costly, you will not do ABG within immediately next, because you don't know ventilator is doing correct or damage. So that is where most of us do mistakes. And you have put the patient on ventilator, within 1 hour you declare the patient, because you are not done the ABG after intubation, after 1 hour or after 30 minutes. So because you are doing it the right way or going the right way, you don't know. So that's the reason, normally in ER also, when the patient comes, I tell, sir, first day we'll be doing at least maybe 3 to 10. And once the patient understand, I would like to do only once in a day, because you don't need to do. Actually, what we look at when the patient is in neurological patients, our goal is only 5H, no, like, high normocapnia, normoxemia, normovolemia, normal ICP. What we have to look at is, you don't have to look at, you look at the SpO2, that's enough. You don't need ABG for them. But you may have to know the PCO2 compressor. If you have ETCO2 intermittently once in 6 hours, you monitor ETCO2, that's enough. You don't need to do ABG this one. And their requirement is not required. So depends on the disease, depends on how many days ventilator is over, your reduction will come down. Previously, when I was working in cardiac OT, what we used to do is, first day we used to do 6th hourly, second day we used to do 12th hourly, third day we used to do once in 24 hours. So to know all other parameters, everything. So depends on that, it actually goes. That's the reason now if you see, why did the monitoring call intrajugular continuous ABG monitoring has come nowadays? Because of this reason. Because to understand whether the perfusion is going on properly to the brain or not. So depends on that we do, but there's no standard. If the patient is stable, vitally stable, when do you repeat ABG? Whenever there is a sudden change in hemodynamic, whenever there is a hypoxia, maybe looking at the pulmonary embolism, looking at the block or ET or those kind of things, you do ABG. Otherwise, routinely, we can do once in a day, very stable patient, neuro patient. Otherwise, in the first few days, 2 times a day. But compulsory, there's a lot of drastic change in the beginning. We should do more frequently, depends on the patient ABG condition of previously what you have done. If any more questions required, please ask me, Omkar.
Thank you, sir. Thank you.
No, am I
Vinay,
clear?
yes, sir. Very good exposure. So, Vinay, what are the indications for
Sir,
bicarb?
అడిగింది ఓంకార్ కదా, ఓంకార్ ఎక్స్ప్లెనేషన్ ఆయనకి నచ్చాలి.
Thank you, sir. Well, very clearly explained, sir. Thank you. Sir, any questions, sir?
What are the indications for bicarb therapy?
Sir, this, I think it, according to books, it's only around less than 7 we need to give bicarb, sir. ATLS, they deny giving any bicarb administration, but in clinical practice, it purely depends upon some nephrologist who doesn't like dropping the bicarb less than 10. And I've seen people starting around, especially in post-CABG cases, the bicarb is dropping down. They start bicarb at even 12 to 14 also, sir.
In diabetic,
Sir, surgical patients, medical patient different, sir. The physiology is different because surgical patients, particularly cardiac patients, so first of all, there is no indication for bicarb. Bicarb is lever kivakudu. As ATLS cheppinattuga Omkaru, please don't give bicarb to anybody. The first question, because there are 4 problems of giving bicarb. When you give bicarb, there is increased acidosis at a cellular level. When you give bicarb, it chelates with the calcium and have a problem. When you give bicarb, there is a, in case of like CPR, the delay in the cardiac activity will be there because of the action potential of the heart muscle cardiomyocyte will be reducing. And it's we give bicarb only to buy a time. It's not a treatment except for 3 conditions. Maybe the nephrologist number, I really don't know exactly. I don't remember that indication exactly. 3 points, like particularly when you're doing an exchange of plasma, or particularly dialysis, when you're doing the bicarb dialysis, and only to buy time we give bicarb because it's not going to treat it. Is harming is more than the benefit. Only when the pH you give less than 7.15, and only till to buy the time till you get the reaction correction, then only we give bicarb. That's what as I know. So there's nothing called bicarb, particularly in our ICUs, we should have, because always treat the cause, either sepsis or hypovolemia, because bicarb our basics will increase when the hypovolemia is there, hypoxia is there. When it comes to cardiac surgery cases, it's an acute condition and you cannot wait like a recovery of the cause for the patients. That's the reason your indication becomes little early in cardiac surgery, unlike ICU cases.
Yes, sir. In ICU cases, there is no indication, sir. Only indication is gasping patient refusing for dialysis. Or like
no,
you said.
and 7.15. It is
No,
an
sir.
indication.
No, sir. Only thing like Monser said to buy time, maybe there is some delay in getting the dialysis and all. Well, just will give 50 ml like that. That also very, very rare, sir.
That's only to buy time. Most of the times
Only to buy time, so that's it. Yeah.
we only give to buy time. It's not for the treatment. There's no treatment with bicarb.
Sure. As you said, that's not a therapy, sir. So practically there is no indication.
But there are 3 things are there, Srikanth. ఒకటి నెఫ్రాలజిస్ట్ చేసేది ఒకటి, ప్లాస్మా ఎక్స్చేంజ్ ఒకటి, ఇంకోటి ఏదో ఉంది గుర్తు రావట్లేదు నాకు.
Ongar da thoracoscopy on.
అసలు యాక్చువల్ గా ప్రీవియస్ గా వెన్ రమణ ప్రసాద్ గారు in the beginning when we were doing my PG at that time, we used to go bicarbonate therapy calculation formula also, and we used to correct totally. So only for some for example, we give bicarb for poisoning, like patients who are having a very less bicarb less than 10 for a slow correction for some poisonings, and we are still giving it, but normally it's only to buy time. It's not, the treating cause is not there.
Sir, whether it is contraindicated in diabetic ketoacidosis.
అదే సార్, కీటోసిస్ లోనే మీరు అది కరెక్షన్ కి ఇస్తారు. కాంట్రాఇండికేషన్ నేను చెప్పట్లేదు, అదే చెప్తున్నాను నేను. ఐఎమ్ నాట్ సేయింగ్ ఇట్స్ కాంట్రాఇండికేషన్, బట్ దేర్ ఇస్ నో రిక్వైర్మెంట్. ఇట్ ఈస్ నాట్ దట్ యూ గివ్ ద bicarb, ఇట్స్ గెటింగ్ ట్రీటెడ్.
One of the endocrinologists told me that in diabetic ketoacidosis, lactate will be converted by the liver to bicarbonate. So the ketone bodies will be converted to bicarbonate. So there is no necessary unless pH is less than 7.
అదే సార్ అందుకోసం ఇవ్వద్దు అని అంటున్నాం. వీఆర్ టెలింగ్ డోంట్ గివ్.
మీరు చెప్పింది కూడా కరెక్ట్ అంతే.
వాట్ ఐఎమ్ టెలింగ్ ఇస్ డోంట్ గివ్.
ఓకే.
In DKA, only fluids, sir, that can save you and the patient.
We are really, you can be really dangerous. You cannot even, once you calculate when the patient comes to DKA, the minimum requirement of the fluid is 6 liters. The problem comes to the patient when the patient comes to the patient. If the patient is having only DKA, you just correct it. But if the patient is having some cardiac problem or ejection fraction is better, put the patient on ventilator or put the patient on NIV if the patient is conscious, cooperative, and start giving fluid still further so that he will not develop pulmonary edema. ఏంటి అనురాధ మంజుల అసలు నోరు మాట్లాడలేదు, కదపట్లేదు, ఉన్నారా లేరా, ఊరికి ఆన్ చేసి పెట్టారా?
ఇప్పటికే సిఏబిజీ అన్నాను సార్, అయినా మేడం మాట్లాడలేదు. సార్ ఐ థింక్ ఎవ్రీబడి ఈస్ what you call busy or else having no doubt, sir.
Very nice class, Dr.
Thank you, sir. Thank you for
moderation.
Sir, because you are only talking, sir. Nobody else participated. Thanks a lot, sir.
Thank you.
Morning.